So welcome everybody tonight. I hope you're gonna have a good time tonight. So a lot of questions come to me during the week, and I'm gonna try to get to as many of them as I can. Based on last week's lecture, I can tell that yeah, we got too much feedback here. Okay, that's better. Okay, so based on last week's lecture, I could tell that people are really starting to think about the things that we're talking about, and I just need to make a couple of tweaks in some of these things and try to just, really clarify and hit some of these things home. But some really great questions came to me during the week, and I think that they really are important for everybody who is in attendance tonight. So I'm going to cover a couple of them. And they're really related to the shortness of breath, the breathing techniques, the exercise, blah, 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 and the oxygen. So the first question is are pulse oximeters reliable enough to use during exercise? And the short answer is definitely yes. Okay, so we use them all the time in our clinic. We use pulse oximeters. It's how we know our patients are well saturated. Okay, and essentially the science behind pulse oximetry is that a light is shown through your finger or your forehead or where it's going, and it's picked up on the other side, and depending upon how much light is actually measured on the other side, we can tell how much oxygen is in your blood. So they're definitely reliable. Things that are going to decrease their reliability, and these are things that you should know. So if your hands are cold, the pulse oximeter is going to be less reliable, okay? If you have very thin fingers, then the pulse oximeter may be less reliable, in which case you should use it on your thickest finger, and yes, you can use it on your thumb. If you have very thick fingers, that's going to decrease the reliability of a pulse oximeter. So if you have very thick fingers, put it on your thinnest finger. Nail polish can definitely diminish the accuracy of a pulse oximeter. And then one other thing is that if your heart rate is very irregular, as an example, if you have atrial fibrillation or you have a lot of premature beats, that's also going to decrease the accuracy of a pulse oximeter. But in general, the pulse oximeter is very accurate, even the ones that aren't that expensive now. And they should be used because we need to know your oxygen and you need to know your oxygen. So the answer to our pulse oximeter is reliable enough to use during exercise, and the answer is yes. One more thing, if you're holding on very tight to the treadmill, that's going to decrease the accuracy. All right, so let's go on to the next question, and that question is, why am I short of breath if my oxygen saturation is above 90%? So that's a great question, and we talk about the fact all the time that that breathing is multifactorial. So there are many things that can make you short of breath. There are many things that can make you less short of breath. But when it comes to oxygen saturation, it's not always a low oxygen saturation that makes people short of breath. In fact, it's almost, not that it's almost never, but that's not really the reason why people are short of breath. They're short of breath usually because of the mechanics of breathing. So we talk about restrictive diseases, things like pulmonary fibrosis. We talk about things like sarcoidosis. We talk about things like interstitial lung disease. And those people are short of breath because they can't take a deep breath. When we talk about restrictive disease, we're talking about a restriction to taking air in. So a restriction to inhalation, as opposed to obstructive diseases like COPD, emphysema, chronic bronchitis, things like that, where people have difficulty with exhalation. But again, it's the mechanics of physically moving air in and out that's making you short of breath, that's increasing the work of breathing. Now, you can be short of breath because of mechanical problems with your respiration and still have great oxygen saturation. And of course, that's a much better situation than being short of breath and having poor mechanics and also being, poorly saturated. Because as we mentioned, once your oxygen starts to decline, there's a whole host of things that go on in your body. Your heart's going to beat faster. Your heart's going to pump stronger. It puts you at greater risk for different types of problems. And so, we're going to talk a lot tonight about, how to stay saturated and why you need to stay saturated. But people need to remain saturated. So let's go on to the next question. So last week we were talking about walking uphill, and I was talking about the idea that you could really get into a jam where you're totally short of breath, okay? And we call that, but we're going to call that code red. So you get to the point where you get up the hill, all of a sudden you're so short of breath, you can't catch your breath, you don't know how you're going to catch your breath. So what do? Okay, let's talk about this. So the question here is, to finish the walk uphill scenario after recovery and breathing techniques, how should you finish the walk? So let's start out with this fact. So it's always going to be better to actually, it's always going to be better to prevent the shortness of breath than to try to recover from the shortness of breath in the first place. So anytime you're breathing, try to use the controlled breathing techniques. Now, I'm going to say in for 2, out for 4 as an example, okay? Now, again, I got a lot of emails this week, even though I talked about it last week. People are telling me I'm only talking about COPD, and I'm not talking about COPD, okay? So keep in mind that it really doesn't matter if you have obstructive disease or restrictive disease or pulmonary hypertension, okay? All of these things make you short of breath. And so if shortness of breath is the enemy, we're going to attack the enemy. And I'm trying to teach you as many different ways to fight that enemy as possible. So just to be clear, okay, in for 2, out for 4 is a good starting point. It works for a lot of people, both obstructive and restrictive. But as we move along, I'm going to teach you how to how to really find your best breathing technique, okay? So let's talk about the scenario. So you start walking up the hill. Start pacing your breathing with your stepping. So as you're walking up the hill, you're breathing in for 2, out for 4, in for 3, out for 6, in for 2, out for 5, whatever the breathing pattern is for you, okay? So start that breathing, timing with your stepping. So if you imagine my hands and my steps, each step is going to be a count. So I'm going to breathe in through my nose, and I'm going to breathe in, low, 2, 3, 4, and I'm going to blow out through pursed lips. So I'm going to breathe in, low, 2, 3, 4. So it looks like this. So okay, so we spoke about the fact that, breath and activity is really a situation of supply and demand. So you may be fine walking on a flat surface, but once you start walking up the hill, you may become symptomatic, or you may be able to walk up, 50 feet up a hill, but once you get to the 85th foot of that hill, you start to become symptomatic. And now we're really starting to get short of breath. So what do? Okay, remember what I said last week. First, talk to yourself. Say, stop. I know what to do here, okay? Think about my face telling you what to do. Recovery from shortness of breath. And remember, when we talk about recovery from shortness of breath, I spoke to you about various positions that you can get into, and we talked about the concept of open chain versus closed chain activity. And we talked about the fact that when our upper body is open chain, meaning that our arms are free, the muscles of the chest, the shoulders, the back, all these things do this. But when we actually fix the upper extremities by leaning on something, okay, or leaning against a building like this and fixing the hands so that the arms come into what's called a closed chain activity, 2 things happen. Your abdominal contents drop forward, clearing the way for the diaphragm, and that makes the diaphragm a lot easier to contract and to take a deep breath in. So again, let's talk about recovery from shortness of breath. Stop, I know what to do here. Get into a position of recovery. Fix your upper extremities somehow, okay, and slowly begin the controlled breathing techniques. Again, in for 2, out for 4, in for 2, out for 5, in for 2, out for 3. And then once you feel like you've sufficiently caught your breath and you've, really calmed down, then you can take off on the rest of the walk at a little bit of a slower pace, taking in the breathing, controlled breathing techniques, and so on and so forth. Now, one thing that I didn't mention last week, which I will mention now and I'll mention again during the exercise lecture, is that your body actually becomes more efficient as you go on longer. So the first 5 to 15 minutes of exercise are actually going to be the least efficient from a metabolic point of view. So that's the idea behind a warm-up, a training phase, and a cool down, which we'll get into in much more detail down the road. But the body doesn't like surprises, so you don't want to just sort of jump up from your recliner and start running for the 7-Eleven or wherever it is you're going. So again, catch your breath, start the rest of the walk a little bit slower until you feel like you've really gotten control of your breathing. Go into the controlled breathing techniques for the rest of the walk. Okay, next question. Can you just give me those as soon as I start talking. Just go to the next question, okay? So the next question is, why do some people have trouble breathing after eating too much food at one time, okay? So again, great question, super common, okay? I hear from my patients all the time. My wife and I went out to dinner last night. I don't understand it. We walked to the restaurant. Everything was great. We had dinner, and I had to take a cab home because I couldn't walk 3 blocks. So again, what are we talking about here? Food, okay, goes into the stomach, right? The stomach contents and the abdominal contents sit below the diaphragm. The diaphragm is the main muscle of inspiration. So if you fill up this area here with food, the diaphragm, which sits underneath the lungs, has to work harder to contract downward. The other thing is that the abdominal contents, okay, when the abdominal cavity is full, that's going to increase the pressure on the thoracic cavity. All of those things are going to make it more difficult for you to take a deep breath, which is exactly why, you know, when we talk to people about eating, we recommend small meals instead of big meals. And then the other concepts that are involved in why it's more difficult to be active after a meal is that blood flow changes. Okay, so when we talk about how your body uses oxygen, there are really 3 major factors that go into this. So the first is, how do your lungs move air in and out? How does your heart pump blood, and how do the muscles use oxygen, or how efficient are the muscles at using oxygen? So in addition to the mechanical obstruction to the diaphragm contracting downward, which makes you more short of breath, there's another aspect, which is that blood flow is now diverted to the gut. Okay, this is the parasympathetic nervous system coming in, and whereas now we're walking again, we really want that blood to be available for our working muscles and our legs. That blood's sitting in your stomach, and that's why after that meal it's very easy to just sit back, relax, and sleepy time. So that is the answer to that. So again, what do? Small meals. Okay, the other thing, alcohol. A lot of times people talk about alcohol, and alcohol is a central nervous system depressant. So that is also has the potential to suppress your respiration. Why do I have trouble breathing in cold and hot weather? Again, these questions are great because it's really, we're talking about a clinic on lung disease here, because these are all the things that people come and complain to me about and tell me they're having difficulty with. So the reasons are actually different, okay? And there are some people who are going to have difficulty in cold weather but not hot weather, and vice versa. One of the things about cold weather, and you know, a lot of the country now is getting whooped by this winter. We are in New York, and it's freezing cold up here. But inside the airways, you actually have smooth muscle. And that smooth muscle is responsible for constricting and dilating the airways, meaning making more or less air available depending upon supply and demand. So as you get moving, as you start to become more active, those airways are supposed to open up so that you can bring more air into the body. When that cold hits those airways, okay, it can cause the smooth muscle to actually constrict, narrowing the airways. So this is going to be a bigger problem for people with asthma, for people with asthmatic components of their COPD, like asthmatic bronchitis, or for anyone who inflammation and airway reactivity plays a big role in their diseases. So one of the things you can ask your doctor about is, you know what, I'm fine in the house, and you know, as soon as that cold air hits me, I feel like I can't breathe. I feel like my chest tightens up, or I feel like my airways tighten up. So one thing that we do with some of our patients, and I'll talk about this in more detail next month when we talk about medications, but you can ask your doctor, would it be beneficial for you to actually take your rescue inhaler, which is your short-acting bronchodilator, or if you don't have one, would it be beneficial for you to have a short-acting bronchodilator to open up the airways prior to going outside, to sort of give you a head start, relax those muscles inside the airways, and hopefully remedy that situation a little bit. Okay, this next question has come to me from about 15 different people in a number of different forms, and it's so important, and it's something that people really don't understand. So pay close attention to this, even if you've been dozing off the rest of the time. My oxygen level drops to 76% after a short walk, but comes back up to 90 fairly quickly, okay? That's important information right there. My pulmonologist says he is not concerned as my body can cope, and my physiotherapist says as long as the level comes up again quickly, that is what matters. I am on oxygen. What do I do? Okay. This is some serious stuff right here. And we talked last week about why 90% is the crucial oxygen that you need to maintain, okay? There are some people who believe that, as this person's, and again, I'm not saying their doctor or their physiotherapist is wrong. I mean, there's a chance that they know something that I don't know, but I will say that there is almost no situation that a patient would be at 76% in my facility without us, employing emergency procedures and actually giving them 100% oxygen. So what do I do? Okay, so let's break up some myths right now, myth busters. And again, like I said, it's possible your doctor knows something I don't know. It's possible your therapist knows something I don't know. But the way that I would do it is like this, okay? 76% is way too low. Okay, it's way too low. So, if you ask yourself the question, it doesn't matter if I hold your head underwater as long as I pull it up, relatively quickly. No, that's not acceptable to me, and that would never happen in our facility. So as I mentioned, we probably use more oxygen than anybody in the country when it comes to rehab. And the reason for this is because whereas programs will actually limit your therapy, in other words, keep you at a low enough workload to keep your oxygen above 90%, to me, that makes no sense. And we figured this out about 15, 20 years ago because we started saying to ourselves, well, okay, if we have to keep the workout at level 4, but your life requires you to be at level 8 or level 9, or even level 7, or even level 5, I could exercise you at level 4 till the cows come home, and that doesn't make you better at level 5, 6, or 7. So our philosophy is totally different. Our philosophy is give you as much oxygen as you need to maintain saturation to get the biggest workout, because the oxygen is not the treatment, okay? The oxygen is not what makes your lungs better. The workout is what's going to make your lungs better. The workout is what's going to make your heart stronger. The workout is what's going to make your muscles better at using oxygen. The workout is what's going to make you able to walk up that hill, do those dishes, pick up your grandchild, blah, 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 whatever it is that you want to do. So, like I said, we're Malcolm X here. By any means necessary, we are going to do whatever it takes to get you the biggest workout possible. Because if your life requires level 5, I'm going to exercise you at level 6, 7, 8, 9, so that you actually have a little bit of leeway in there, to live your life, okay? So let's talk about this for a second. My oxygen saturation drops to 76 after a short walk. So what could you do about that? First of all, that's a problem to begin with. So the first order of business is you need to increase your oxygen. Now, some people are saying, but my concentrator only goes up to 5, and that's on 5, or they only told me I was supposed to use the concentrator on 2. No, if you're 76%, you don't get any clearer indication that you need more oxygen than that, okay? So first thing is, if you're at 76%, crank up that oxygen. Now, if the majority of people use cannulas, okay, the prongs that go in your nose, and one thing to understand about the difference between a cannula and a mask, and the reason why we use a mask so often with people, especially who desaturate very quickly and very low, is that the cannula is a low flow system, okay? And what that means is it doesn't matter how much oxygen you pump through that cannula, the maximum it's going to be able to give you is 40% oxygen, because by nature of the limitation that the nasal cannula is a low flow system. So the max is going to be 40%, 41, 2, 3, 4%, but any more than that, okay, is wasted on you. Okay, so in that situation, if you're getting the highest amount of oxygen that your system delivers, whether it's a concentrator or a tank or a liquid oxygen, if you're getting the highest amount possible and you're still desaturating, then we need to go to a high concentration delivery system, and that's where we'll use a mask. So the beauty of a mask is that the mask can actually allow you to go up to 100% oxygen on 15 liters. Now, the overwhelming majority of delivery systems will not give you 15 liters, okay? But if that's the situation and that's what it takes for you to remain saturated, then a tank is really your only choice. And so if I had a patient whose saturation drops to 76%, I would be exercising them on a mask at 100% oxygen, and I would keep the workout low enough for them to be able to do it, and little by little we would start gradually increasing the workout. And this is a complex topic here, but again, it doesn't mean that, just because you rebound quickly that it's not okay. And with respect to somebody saying that your body can cope, There absolutely is some truth to the fact that over time, people who spend time, being desaturated, their bodies do make adaptations, but don't get the idea that it's okay and it's healthy for you. Being, not having enough oxygen in your bloodstream can lead to coronary ischemia, meaning that your heart is not getting enough blood. It can lead to arrhythmia. It could lead to a whole host of, cardiovascular, electrical, neurologic problems, and it's just not a good scenario. It's not what you want to be doing on your regular basis, and on a regular basis. And so in our situation, we are going to give you as much oxygen as it takes to keep you saturated. And if we can't, then we will try lower level activities before trying to work you back up. So maybe instead of the treadmill, we'll start you on the bike and build up your aerobic system, by getting up to 30 minutes on the bike, 30 minutes of the arms. But you do not want to be desaturated on a regular basis. All right, next question. Is there a formula for people with COPD, IPF, pulmonary hypertension to determine their target heart rate while exercising? So now, let me tell you something else, and this is something that I can pretty much guarantee you based on more than 60,000 exercise sessions with people. The target heart rate for pulmonary patients is really something that has no place in pulmonary rehab or pulmonary exercise. And the reason is because it's not usually a heart limitation. Okay, the target heart rate has to do with where is your body going to get the best cardiovascular workout. And the fact of the matter is that in almost all cases of people with lung disease or respiratory disease, the limiting factors in exercise are either going to be shortness of breath and lower body fatigue. So your legs get tired, you get short of breath, you have to stop the activity. And usually this happens before you actually reach a hemodynamic endpoint, meaning before your heart is actually limited. So to set a target heart rate for that really doesn't make much sense. And so the goal would be, well, let me say one other thing first. The other aspect of that is that, really there's no one target heart rate for everybody. But other aspects are that a lot of the medications that people with pulmonary disease take are actually stimulants. And so a lot of times people are resting at higher heart rates than they would normally. And the other thing is that very often people with lung disease have, their work of breathing is so high that you're actually working hard even when you're sitting and doing nothing. And so you might have a high resting heart rate. So very often target heart rate is based on your age. So just as an example, if you're resting at 100 or 105 or 110, you might already be at your target heart rate based on cardiac numbers. But we don't use a target heart rate here. Essentially what we do is we have a target limit. So what we'll do with our patients is in most situations, okay, and there are definitely situations that we make some modifications to this. And again, this is not what I'm telling you what you should do, but ask your doctor. But what we do here is we generally allow people to go to 200 minus your age. And notice I'm not giving you a set number, okay? So keep that in mind also, because a lot of times, and one of my big, theories as to why people don't work pulmonary patients out harder, or why they don't work, pulmonary hypertension patients out harder, is really fear. And it's not just fear on behalf of the patient, it's fear on behalf of the clinicians. And so I think that, like I said, if you don't know if you're going to be able to keep your breath, or you don't know if you're going to drown, you're not going in the water, or if you don't know if you're going to be able to catch your breath, you're not going, for that walk to the grocery store. I think it's the same way with a lot of clinicians. And when I talk to people around the country, I know that there's a lot of fear out there. So as an example, I just got back from a national conference in Nashville where they were saying that for pulmonary hypertension patients, the maximum heart rate should be 120, okay? So to me, when I hear somebody say something like, well, the maximum heart rate for everybody with this disease should be any number, I don't care if it's 180, 200, 250, or 500, okay? If you're telling me the same number for everyone with the disease, then I know that you don't, there's one of a couple of things going on here, which is that either you don't really understand the disease process very well, or you don't understand the exercise physiology or the pathophysiology behind how these things work. Because I have patients with pulmonary hypertension who are 75 years old, and I have patients who are 30 years old with pulmonary hypertension. And as I mentioned before, we use 200 minus your age. So clearly age is a factor in what's okay and what's not okay. So how could a person who's 75 years old have the same heart rate limitation as someone who's 30 years old. And I think what it's going to take over time is just for people to push the envelope. And when I say push the envelope, I'm not talking about doing something crazy or risky. I'm talking about safely, under monitored conditions with the right safety controls built in, and little by little allowing people to do more and more and more, and saying, well, they were okay, so it must really be okay. That's how, we find out things in medicine. I mean, we have to let people know that the world is round, and people don't have to sit in their chair waiting for the big one, but that's only going to happen if it's done safely by people who are really comfortable and really understand the physiology behind this. So is there a formula for a target heart rate in COPD? My answer is no. My answer is do as much as you can, but generally keep your heart rate below 200 minus your age. And again, talk to your doctor about that. So here's a question. Would you please discuss breathing exercises for pulmonary fibrosis and restrictive lung disease? So again, I was looking at the message boards again this week, and I see people talking about the fact that they were disappointed because I only talk about COPD. And let me tell you something. I love taking care of people with restrictive lung disease. So don't let it be known that I only take care of people with COPD, because it's not true. And restrictive disease is a super area of interest of mine, because I don't think the majority of people really know how to rehab people with restrictive diseases. So again, when I was talking to you about the different breathing patterns, I was talking about people with COPD, pulmonary fibrosis, pulmonary hypertension, anybody who is short of breath, okay? This can work for anybody, or it may not work for anybody. So what I was trying to get across last week, and maybe I didn't get it across as clearly as I would have liked to, but I'm going to try to get it across now, is the following, okay? We use in for 2, out for 4 as a starting point. In any project that you do, or in anything that you want to undertake, you need an initial ink stroke. You need something that is going to put the pen on the paper and get it started, and based on that, you can make adjustments to it. The reason why in for 2 and out for 4 is so great is because, again, people have difficulty, okay, and now I am going to talk about COPD for a second. So for obstructive diseases, okay, the difficulty is blowing air out. So when you do pursed lip breathing and try to prolong the exhalation, you're actually doing 2 things. Number 1, the pursed lip breathing, and this is good for obstructive and restrictive, but by pursing your lips, you're actually creating a back pressure, and that back pressure gets reflected back into the airways and back into the lungs to help the airways stay open longer, and to help the air sacs prevent from collapse. And again, that is more of an obstructive disease thing, but it also can be a factor in restrictive disease. So I would always say to people, start with in for 2, out for 4, and then make a modification to it. Now you may say, well, how am I supposed to make this modification? How am I supposed to know what's good and what's not good? Let me give you a restrictive thing for 1 second. So with restrictive diseases, we know that there's a problem with inhalation. So we want to prolong the inhalation for as long as possible. So if a lot of people say, well, I can't breathe in for 2. But if you remember when we were talking about the trachea, and we talked about the fact that air in the trachea cannot actually be used by the body. So it's really important, as best you can, to try to overcome that trachea and move that air past the trachea. So here's a chart that I made. It's very complex. All you have to do to understand this chart is be able to count from 1 to 6 and know the difference between inhalation and exhalation. So here is how I would suggest to you to find out what is the best breathing pattern for you, okay? Try all of these. So let's start with inhaling for 1. So start by inhale for 1, exhale for 1, and that looks like this. We know that's probably not going to be effective for the majority of people for a number of reasons. It's a very short inhalation, meaning that a very low volume of air is actually going to get into the lungs, and that in and out, in and out, in and out is what most people find themselves doing in distress, okay? So now I know that's not going to work. So I'm going to say, okay, in for 1, out for 2. Well, that's a harder thing to do because I'm only breathing in for 1. How am I going to blow out for 2? But my point here is try these different numbers. So if in for 2, out for 4 doesn't work for you, try in for 2, out for 3 if you can't hold your breath in for 4 counts. Or if 2 is not enough for you to take a deep breath in, try in for 3, out for 4, or in for 3, out for 5, or in for 3, out for 6. My whole point is that there's not one breathing technique that's going to be best for every single person with obstructive disease. There's not one breathing technique that's going to be best for every person with restrictive disease, and there's not one best breathing technique that's going to be best for every person with pulmonary hypertension. So find a baseline, try them all out at different levels of exertion, and see which works best for you. And you may find that working out at a light level of exertion, you may find that one pattern works better for you than working out when you're walking up that hill. So again, experiment with them, okay? We start with 2 and 4 for everybody because it is the pattern that works with the majority of people, okay? But once we show that 2 and 4 is tough, we work on other things and we try to find other ways. All right, so I hope that clears a lot of things up. And now we're going to start going to some questions from the audience, and we're going to start bringing some people in. So we're going to talk to Patricia S., and hopefully Patricia S. is there. Are you there, Patricia? Patricia, are you there? Same question. That's the same question we just said. Okay, it seems like Patricia is having some technical difficulties. Audrey, would you like to ask your question? Is Audrey B there? Audrey, can you hear me? Hey Audrey, I can hear you now. Yep, so what is your question, ma'am? Okay. Okay, so that's a great question, okay? It is, the question is, what would be better for exercise, a stationary bike or a treadmill, okay? So let's just talk about some concepts about what makes something a good exercise machine versus a bad exercise machine. So start off with the fact that it's always better to do something than to do nothing. So it doesn't matter what machine you have, if you hang your clothes on it, which is what a lot of people do, it's not going to help you at all. Now, last week I mentioned that if I only had one piece of equipment, the piece of equipment that I would choose to work people out on is the treadmill. And the reason for that is that it's walking. So essentially, the majority of us walk, and the majority of us have difficulty when we're walking. And it doesn't matter if we're walking on a flat surface or walking uphill or walking upstairs. The muscles that you're going to use on a treadmill are going to be most consistent with the activities that give you difficulty in your everyday life. Now, most of us don't bike. Not to say the bike is a bad machine, and if it's all that you can get, okay, if you don't have access to a treadmill, then biking is certainly better than nothing. But in addition to your biking, I would also add in a walking program, even if it's just walking on the sidewalk or walking around the mall. So in my opinion, there's a lot of different machines that you can use. I'll talk about some of them. There's pros and cons of each, okay, but there's generally benefit to most of them. So when it comes to the treadmill, okay, I think the treadmill is the greatest machine for a number of reasons. Number one, it's walking, as I just mentioned. It's the most functional activity. It's what most of us have difficulty with, but it's also extremely controllable. So we have a great ability to know exactly how hard you're working because we're setting the machine. The machine is going to be set at 1.6 miles per hour with a 2.5% incline. We know what the metabolic level of that is, and as a result, we have a very clean idea of how hard are you working, okay? Now, for people who can't use a treadmill or who don't have access to a treadmill, walking outside is great for you, okay? Or walking around your house if it's too cold outside is great for you. Walking is walking. It's the single best exercise in my opinion, and it's essentially almost universal, okay? A bike is great for you, okay? So the benefits of the bike are it is aerobic, like the treadmill, okay? And our goal in all of these exercise sessions is to do what's called aerobic activity. And the aerobic exercise really has to do with making your body a bit better at using oxygen. And so it's going to hopefully improve the mechanics of your lung, which, if you read the literature, 99.9% of the people are going to tell you that no, you cannot improve your lung function, but we believe that you can, and we have proof that you can, which we hope to publish later this year. But all of these aerobic exercise should hopefully help you improve lung function, help the efficiency and the strength of your heart, and also help the efficiency of your muscles. So we want things that are going to be aerobic in nature. So the stationary bike is great. It uses big muscle groups. It uses muscles of the hips, the legs, which is great. The problem with it, and the reason why I don't love it for either exercise training or exercise testing, is that a good amount of your body weight is supported. Okay, so when you're actually walking, you are responsible for holding yourself up. There's actual balance between the muscles that are preventing you from tipping over right or left, front and back. There's a whole lot of things that go on, and you actually have to pick yourself up and move yourself, as opposed to the bike where you're really, most of your body weight is supported and you're just moving your legs. Same thing with the upper body ergometer. I think the elliptical machine is great because you get the opportunity to use arms and legs, which is always a plus. But to get to your specific question, given the choice of a stationary bike or the treadmill, I'm going to choose treadmill every time. And likewise, we have a lot of different equipment in our gym, but I could get people in the exact same condition with just a treadmill as I do using all the other pieces of equipment. It's just that it's not as interesting to just do treadmill. So my vote is always going to be treadmill for exercise testing, for exercise training. Next question. So let's go to Sherry. And I know you, Sherry. I think I saw you at the stair climb this weekend. So Sherry, are you with me? Sherry, I can hear you, so talk. Okay, Sherry, welcome. So what is your question tonight? I did see you at the stair climb, right? Okay, that was you. I knew that was you. Okay. 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 So with a decongestant, we're talking about a pill? Okay, so very often physicians don't want their patients taking the decongestants. They do a lot of different things. First of all, they constrict the blood vessels, and they can also be very drying. So remember, we talk all the time about how the respiratory system really likes to be moist. And so I can't say exactly why was your mother more short of breath or why did it make her breathe heavier. But if the blood vessels are constricted, that makes the heart work harder. If the airways dry out, that's going to make it harder to move air in and out. And again, we're talking about the efficiency of using oxygen. So when we talk about the efficiency of using oxygen, we're really talking about when we talk about a car, we're talking about miles per gallon. So as I mentioned last week, if you don't have the right amount of air in your tires and your oil filter is dirty and your spark plugs are old, you're going to get less miles per gallon. When we talk about oxygen, if we talk about how good is how good are your lungs at moving air in and out, how good is your heart and the vascular system at delivering blood, and how good are your muscles at using it, a decongestant, even though it can help clear you out a little bit and relieve some sinus congestion and some congestion, it can also have a negative impact by causing vasoconstriction, meaning the blood vessels constrict and really drying out the respiratory system. So I can't say if that's why your mom specifically was more short of breath, but anytime, there's a lot of drugs over the counter now, things like Claritin that were never over the counter before, or Claritin D. And a lot of people get the idea that over-the-counter means that it's essentially benign. And particularly when you have other diseases or medical conditions, that's not always the case. So anytime you take your over-the-counter stuff, it's always a good idea to check with the physician first and see if maybe there's any interactions with any of your conditions and or other medications. So next question is going to come from Jean R. So Jean, are you there? Is Jean with us tonight? I hear you, Jean. Okay. Welcome. Where are you from, Jean? Okay. All right. So what's your question for us tonight? Absolutely. So when you say whatever you're comfortable with, what can you just clarify that for me? What do you mean? Right, absolutely. So, okay, so that's very good questions, and you know, again, part of the reason why we do this webinar is because, you know, there's so much misconception out there. So let's talk about how do you prescribe oxygen at safe levels. So very often oxygen is prescribed really not giving any, not really paying attention to how the patient does when they exercise or when they move around. So ideally what would happen would be, you know, let's say like you're going to get a custom-made suit. So the way you make a custom-made suit is you take measurements. You measure the waist, and you make the waist to that. You measure the length, and you make the length to that. That's how it's really supposed to be with oxygen saturation. And unfortunately, and sometimes it's related to insurance, sometimes it's related to, you know, misconception on the part of the physician, or sometimes it's related to just, you know, not really doing enough testing on the person. It's very hard to know what's acceptable and what's not acceptable. And then you have the other factors involved, which are, you know, how are we going to deliver this oxygen? And so patients want oxygen delivery systems that are going to last a long time, that are going to be lightweight, that are going to keep them well saturated, and that are going to be inexpensive. So there's so many factors that have to get weighed in. But it's very simple. Like if you want to keep your bath at 77 degrees and you have a thermometer telling you what the actual temperature is, if it goes to 76, you're going to increase the hot water. If it goes to 78, you're going to increase the cold water. And that's essentially what should happen with oxygen saturation. So first of all, we have to take some measurements. So if I were going to tell you how much oxygen you should use, the first thing we're going to do is we're going to start you with as little oxygen as possible. So let's say I have a patient who doesn't wear oxygen in their everyday life, but we know we're going to have to exercise them with oxygen. So what am I going to do? Again, I look for a starting point. So the starting point, if the person is on the smaller side, might be 2 liters per minute by a cannula. If they're on the bigger side, it might be 3 or 4 liters per cannula. And then we're going to titrate that based on the actual oxygen saturation measurements that we get. So if the person is exercising and they're still at 88, I know that 88 is enough to actually get some of these negative things rolling that I talked about. So I'm going to increase that person's oxygen by 1 liter at a time until I have a very good sense of what does that person need for the various activities. And so as an example, somebody might need 2 liters on the upper body ergometer and the bike, but we may have to increase them to 4 liters on the treadmill, or they may need, you know, 4 liters on the bike and the upper body ergometer, but on the treadmill we have to switch them over to a mask because they require more oxygen. So it definitely seems like you understand me very clearly. And then the other factor comes in with a lot of these new portable oxygen concentrators, because there's so many misconceptions related to those, because people get these concentrators that say 2, 3, 4, 5, 6, and they think that that indicates liters per minute of oxygen, and that's really not the case. It's really just a setting on that device, and we find out, you know, when we look at the fine print, that many of these devices can't even deliver more than 1 or 2 liters per minute. So it's real important, I agree with you, to keep taking measurements and, you know, use your saturation number to determine, are you okay or not, are you not okay. And then the only way that we're really going to know are you truly getting 2 liters per minute or 3 liters per minute, is if you're using a tank of gas oxygen. And then we know you're actually getting those liters per minute. The concentrators are not always accurate, okay? And don't write to me if you're a concentrator company and tell me, yes, they are, because, you know, I see it all the time. Patients on a concentrator, they're on 3 liters per minute, and their oxygen saturation is 92%, and then I put them on 3 liters per minute with full gas, and they go up to 98, 99, 100%. So these are all confusing factors, but you are correct, okay? My firm belief is that you need to give as much oxygen as necessary to keep a person saturated, because once that person is desaturated, you're almost defeating the purpose of any exercise you're doing. All right, let's go on to Pat W. Pat W., are you there? Pat, can you hear me? Pat W., can you hear me? All right, I will read Pat's question. So Pat's question is, how is atrial fibrillation affecting my COPD? So, interesting question. Okay, so for those of you that don't know, okay, the atrial fibrillation is an irregular heart rate, and it's triggered by the atria. So essentially the heart has 4 chambers, 2 upper chambers called the atria, which are the filling chambers, and two ventricles, which are the lower chambers and the pumping chambers. So when you have, under normal circumstances, both your atria contract together, filling the ventricles with blood, then the ventricles contract and eject blood from the heart. When you have atrial fibrillation, okay, the atria don't really contract in a nice A-B format as they do under normal rhythm. What winds up happening is the atria sort of just quiver around because there are multiple irritable areas of the atria, and so depending upon when the atria actually contracts, there's going to be varying levels of blood in the ventricle at the end of filling. So that could mean that some strokes have 40 milliliters, some strokes have 60 milliliters, some strokes have 80 milliliters. So how does AFib affect your COPD? There's no way to say exactly how it affects it, but the one thing I'll say is that, again, think about it from the perspective of the lungs, the heart, the muscles. Any decline in any of those areas is going to contribute to more difficulty. Now, one key factor when it comes to atrial fibrillation, there are many people who are in chronic atrial fibrillation. And by that I mean they are, it's something that they live with, and their heart rate is irregular, but the key factor is the ventricular rate. So there are some people who have what we call rate controlled or V-rate controlled atrial fibrillation, meaning that their ventricle contracts, or their ventricular rate is slow enough that they actually get plenty of filling and cardiac output is not impaired significantly. And then there are people who have episodes of what's called rapid atrial fibrillation. And the problem with rapid atrial fibrillation is that the heart rate, the ventricular rate, actually increases so much that there's no filling time. As a result, cardiac output comes down. All these things can make you more short of breath. So the keys to COPD and atrial fibrillation: good control of your atrial fibrillation, anticoagulation, meaning making sure that the blood is thin enough, and then also with atrial fibrillation, you have to be a little bit careful with some of the inhalers, because those can actually either increase the frequency of the atrial fibrillation or increase the rate of the ventricles. Next question. So Stephen C., are you with me? Stephen? Can you hear me, Stephen? Is Stephen with us, or is Stephen having technical difficulties? All right, so I'm gonna interpret what I believe to be Stephen's questions. Okay, so one of them is, or actually, do we have the actual questions themselves? Okay, so let's go to the first question, Nicole.
Stephen's first question was, what about posture while walking? Is head held high and very erect significantly better than if your head is hanging forward?
Okay, so posture while walking. Okay, this is a very important topic, and it's not just posture while walking, it's posture in general for people with lung disease. Okay, just think of it like this: anything that brings you up and out is going to be, suggestive of improved inhalation. So that's going to make it easier for you to breathe. So if you're walking all hunched over, the respiratory muscles have to work that much harder to actually take a breath in. So I'm always going to recommend people stand upright as best they can. An exception to that might be somebody who's walking with a walker or a cane, and we talked about, again, closing the chain. So when you close the chain and actually use a walker in a closed chain, that walker, in addition to providing you support for your lower body, will also provide support to the respiratory muscles by allowing you to take a deeper breath by improving the mechanics of breathing. And then there's a second question there. Is there?
The other question's a bit longer. It's that a couple of days ago, his pulmonologist increased his prescription from 2 to 4 LPM up to 8 to 10 LPM, and he doesn't yet have the upgraded equipment options from his O2 provider. Is there something else he should insist on? Should he be wearing a mask around the house?
Okay, so first of all, if you do have a mask, then absolutely, because before, as I mentioned, a mask is a high concentration device. So even if you only have 2 liters per minute or 4 liters per minute, by using that non-rebreather mask, it's actually creating a reservoir, ensuring that whatever air you do take in is at a higher concentration. And then the other thing is that if you do require 8 to 10 liters, then you can only be on a mask. So a lot of times I'll see people who will be on a nasal cannula and they'll say we need more oxygen, therefore we'll increase it to 8 or 10. No good, okay? Because again, the most that a nasal cannula can handle effectively is 6 liters per minute. So the fact of the matter is that 6 liters per minute is the glass is full. Anything additional you pour into it just winds up on the table as waste. All right, so Patricia B, are you with us? Patricia B, are you with us? Hi Patricia, how you doing? So you have a question for us, sure. Okay, I think the New Step is a great machine, okay? We don't have them here for the simple reason they're gigantic. But I think it's a good, I think they're, in the same ballpark, okay? I think the New Step and the bike are in the same ballpark. I think the benefit is that some New Steps, if I'm not mistaken, you can use your arms as well. And it's always better if you can use 4 extremities instead of 2. You're getting a more aerobic workout. But again, I don't think, and this is something that I'll say over and over again, I can get you in shape with any machine, and I can get you in shape with no machines, okay? If you really know how to take yourself through the workout, then you can get a good workout on any machine. So I think when it boils down to what should you buy, and again, after the treadmill, because again, I think the treadmill is head and shoulders above any of the other ones. But then after that, I think you really have to go with what do you like, what are you really going to use? Because the overwhelming, you could go on eBay at any time and buy any piece of equipment that says barely used, and that is true. I mean, I've bought so many pieces of equipment that I've used once, twice, 3 times, 5 times, and then you never touch it again, and you look at it and it makes you mad to see it. So I think the New Step's great. I think exercise bikes are great. I think treadmills are the best. But I think any machine that's going to get you exercising on a daily basis as opposed to doing nothing is a plus. Is Barbara available? Barbara C, are you there? Barbara C, are you with us? Okay, do we have somebody else?
Barbara's question was very closely related. It was, would you recommend using the Gazelle in addition to a treadmill? Her facility used it, but she was never sure if it was really effective.
Okay, hold on one second because I don't know what the Gazelle is. I'm going to look it up right now and see what this is. Okay, so the Gazelle. So the Gazelle is essentially sort of like a arc trainer / elliptical machine. It's more like an arc trainer than anything else because it's not elliptical. So let me just break it down to you, okay? What we do with our patients is again, the treadmill is the main meat. So my first choice is always going to be build your workout around the treadmill. And what we do with the majority of our patients is we do anywhere from, usually 20 minutes of treadmill, 10 minutes of an upper body ergometer, 10 minutes of bike, and that's the crux of our program. Okay, and people are saying, well, wow, what's so special about the program? Everybody does bike and treadmill and UBE, but it's not what is the machine you're using. It's what is the workout you're doing and what physiology are you harnessing in order to allow the person to get the greatest workout. So would I recommend the treadmill in addition to the Gazelle in addition to the treadmill? Absolutely, because here's the benefits. You get the benefit of doing the treadmill, and you get the benefit of the Gazelle. So the Gazelle is going to work your body in a different way in the sense that the leg movements are different than the treadmill, in the same way that if you do a Stairmaster versus a treadmill, the leg movements are different, so you're using different muscle groups in different ways. And the Gazelle allows you to do all 4 extremities at one time, and there's huge benefit to 4 extremity exercise. So I'm going to say cross training is really where it's at. So if you don't have access to a treadmill, then we're going to find ways to get you in shape in other ways. But if you have a treadmill, and you can also add in the Gazelle or the UBE or the elliptical or the New Step or the bike, it doesn't matter what it is. The more variety you do, the more cross training you do, the more complete your workout's going to be. But you have to, the only difference or the big difference between the treadmill and everything else is that on all these other machines, the intensity is really controlled by the patient, as opposed to the treadmill where the intensity is really controlled by the machine. So you can take the Gazelle and you can work real hard on the Gazelle, or you can take the Gazelle and you can work real easy on the Gazelle. But my preference would always be to do a big treadmill workout, of at least 20 minutes, supplement with 10 to 15 minutes, 20 to 30 minutes on the treadmill, supplement with 10 to 15 minutes of whatever other exercises you have. If you can throw flexibility exercises into it, great. If you could throw strength training exercises into it, great. The more cross training you do, the more you're going to be able to do. The more you ask your body to do, the more it could do. Very simple. Does anyone have any other questions? All right, Patricia B, are you with us yet? We're going to try one more. I know you have one more question. Patricia B. Okay. Do I think yoga and Tai Chi are beneficial? Absolutely. I think they're beneficial in different ways than the aerobic exercise that we're talking about. So, there's a huge variation between different types of yoga, and also there's variation in Tai Chi. So, while I wouldn't probably choose yoga or Tai Chi as my number one aerobic trainer, because in many cases, and please yogis and Tai Chi masters, don't call me and say that you can get a vigorous workout from it, because I know you can, but it's not going to be as vigorous and aerobic and cardiovascular workout as a vigorous treadmill workout, okay? So I think those things are great to supplement, and I think the benefits of them are flexibility, and for people who have difficulty breathing, the muscles get very, very tight, okay, particularly in the chest, the back, the neck, okay? So I think that the stretching and flexibility components of them are great. I think the relaxation and stress management components of them are great. I think they work to quiet the nervous system, particularly the sympathetic nervous system, to help, create a state of relaxation and decrease blood pressure, decrease stress and anxiety. And I think the breathing techniques are effective. Again, I would never say to you, don't do yoga breathing when you're doing yoga, because, there's something to it. I love yoga. I love Bikram yoga in particular, but I try to keep my mind open to things and say, okay, well, there must be a reason why this is done this way. So I would say, if you can stick to the breathing that, they're teaching you at yoga, and that's effective for you, get the great workout that provides. And if you can't and you have to make a modification because of your lung disease, then by all means do that. But, absolutely, yoga, Tai Chi, I believe in anything that will help you. So massage, reflexology, Rolfing, acupuncture, whatever it is that is going to get you to, get you to get stronger and feel better. I don't care what it is, just do it. Again, it's important that you just do something. So, Vladi, are you with me? Hello, sir. How are you? We've communicated numerous times. Okay, so what is your question, sir? Okay, so what should you be doing? What exercises should you? Okay, so what we do in our program is we essentially have our patients come in and do the aerobic component of the program first in order to make the body more efficient at using oxygen. Now, can you do the weight training program first? Yeah, but I'd rather do the aerobic component first while you're fresh, because that's the single most important thing for people with respiratory disease. So generally, we'll have our patients come in, do 40 minutes of aerobics. The most common scenario would be 20 minutes on the treadmill, 10 minutes of bike, 10 minutes of upper body ergometer, and then we'll do strength training. So strength training, and in 2 months, there's going to be a full lecture, one of the big lectures on exercise. But when we talk about weights, what is the purpose? So the purpose is to increase strength, increase muscle mass. And essentially what we're talking about is progressive resistance. When we talk about strength training, we're really talking about how do we get the best workout. And there's different things we can vary. We could vary the exercise itself, okay? We can vary how much do we lift, the weight, and we can vary the number of reps. So there's a big sort of debate between should we do high weight, low reps, should we do low weight, high reps, and I could make an equal case for any of the above, and you really have to ask yourself what is your biggest problem. So if we start with a scenario of lower weights with higher reps, okay, that would be something, any type of exercise in, let's say, the 12 to 20 repetition range with a light weight. So the benefit of that is that you do get some strength training benefits, but you also get some aerobic training benefits with it as well. A lot of programs do an upper body program called Armor Size, where it's essentially 15 different exercises that we take you through, and it gets to work the muscles in different way, and you can do that with weights as well. But the choice is really low weight, high reps, or high weight, low reps. And higher weights with lower reps, so anywhere from, let's say, 4 repetitions to 10 repetitions would be considered higher weight, low reps. So there's benefit to both. You're definitely going to get more strength gains from doing lower repetitions with a higher weight. You're definitely going to get more muscle gains from doing higher repetitions with lower repetitions with a higher weight. You're going to get more general fitness and aerobic benefits from doing higher repetitions with a lower weight. In general, again, I would say mix it up. So, I would recommend a pyramid type system. That's what I do with a lot of our patients, where let's say you might start off with 15 repetitions of a light weight, and then you might do, increase the weight a little bit and do 12 repetitions, or increase the weight a little bit more and do 10 repetitions. But generally what we do is we wait until somebody could do 15 repetitions with a weight, then we increase the weight and drop their repetitions down to 10 in the next workout. Then when we work them up to 12 and 15, and then when they can do 15 again, then we increase their weight again. So as far as what are the actual exercises, there are billions of weight exercises you could do. There's a whole host of things you could do. In general, you want to do things that work the larger muscle groups and compound exercises. So you always want to work the larger muscle groups first. When you're fresh, work down to the smaller muscle groups. And what do we do here? We have weights that we do with free weights, but we also have a stack where people are doing things like pull downs to work the back muscles, bench presses to do the chest muscles, overhead presses or laterals to do the shoulders, bicep curls, and then tricep push downs. But that's generally the order in which I would do. So I would always do, given the choice, I would do legs first. I would start the program with legs because that's the biggest muscle group. I'd go to my back next, and the reason why I would do back before chest is because many people with respiratory disease, and generally humans in general, because we do almost everything here, wind up with a rounded shoulder, tighter front of the chest, and weaker muscles in the back. So I'd always do the back first, then I do my chest muscles, then I do my shoulder muscles, then I do my triceps, then I would do my biceps, and that's your workout right there. I'll do more about the weights and give you photographs and programs when we do exercise specifically in 2 months. Any other questions? Any other questions? It's 8:35, so we're actually not that over. I see something. Do I see any other questions online? Last chance. Any questions? Going once. Do we have any other questions online? All right, so I thank you very much for your attention. I thank the people, for signing in every week. I thank all of the people that help us spread the word. I ask you, if you're a member of a Facebook page, online support group, in-person support group, please spread the word. Spread it to your rehab facility. Spread it to your doctor. We will be here next week. Another Q&A question, and I'm not going to, if you want to send me actually, I got a question. I got a really good question emailed to me before. Hold on one second. Could I have that sheet in the paper? I do have one more question. This is a good one. So this is a really great question, and it's right up my area of interest. So this one says, is there any special care that should be taken in pulmonary rehab patients with pulmonary hypertension? I have read that people with pulmonary hypertension shouldn't do weight training, okay? And that is from Kim. So I thank you for that question. I'm going to say that there are no absolutes, okay? And pulmonary hypertension has many different types and many different levels of severity to it. So I would never say that A patient with this should never do that across the board. We have pulmonary hypertension patients, and I wish I had the photograph here. I have a 30-year-old hypertension patient who we have lifting weights. If you want to see a great picture, go on our Instagram. It's at Instagram.com, and we're under Pulmonary Wellness. One of our young pulmonary hypertension patients is lifting weights, and she's flexing her biceps. And I hope that someday my biceps can be as good as hers. I don't believe that there's an absolute that people with pulmonary hypertension shouldn't do weight training. In that case, I would definitely err on the side of lighter weights, okay, increased repetitions. But, again, in the same way that we talked about how do you know if you're getting enough oxygen before, if I get my pulmonary hypertension patient lifting weights, what do? We monitor them. So we start where all our patients are always on EKG. So I'm looking at your heart rate and rhythm. Okay, I will check your blood pressure. So the big issues with pulmonary hypertension are going to be increases in pressure. So check the blood pressure, systolic blood pressure, diastolic pressure. If everything looks cool and the oxygen saturation is fine, I mean, by taking vitals so frequently, we're not guessing anymore. We're not saying, do we think we're okay? We're saying we know you're okay. So I would say under the right circumstances, people with pulmonary hypertension definitely, I shouldn't say definitely can, but under the right circumstances, the right people with pulmonary hypertension can do strength training. I would definitely recommend, monitoring it very, very closely, especially at the beginning. And then the key for all patients is don't hold your breath, particularly with pulmonary hypertension patients, because holding your breath, aka the Valsalva maneuver, is going to increase all your pressures, making it more dangerous for you. But make sure real deep breathing coordinated with your exercise, so always blowing out on the exertion. And I think pulmonary hypertension patients definitely should exercise and probably can do weight training. So last chance, any further questions before we break for the week? We do have another question. Who is it from?
Stephen C.
Stephen C., are you there? Stephen C.
Stephen's question was, I seem to get better saturation while lying on my side at night rather than on my back. Is there a reason for this?
My guess is that, okay, so here, I'm not going to guess on it. I'm going to think about it for a second. So when you lie on your back, okay, think about what's going on here. So you're lying back, everything is stretched pretty tight, and that's going to increase the intra-abdominal and intrathoracic pressures a little bit, giving you a little bit more resistance to diaphragmatic contraction. When you lie on your side, you're actually, it's a lot more room in the abdomen for the diaphragm to contract downward. And very often when we start teaching people with diaphragmatic breathing, we actually do it in side lying. So I think it really has to do with the mechanics of respiration and the fact that your diaphragm has a little bit more room to move, and as opposed to lying flat on your back. And I think with that, we are going to call it a night. So thank you all very much. Please fill out your post-seminar surveys, and I hope to see you next week. Have a good week.